Hi, Don here. Welcome to the $1 Million Minute. I'm going to go through the things that help my practice get to the $1 million mark and beyond. Kind of what I was working on today. There was something I put together a few years ago. I call it the kind of a plantar fasciitis course. So the website that I use is called Kajabi, and on there, I guess one of the benefits is that you can put together courses and you can sell them. I haven't been too successful at selling things for our office website, but I did put together this course, and I made it kind of as a kind of a highlight for the website at this moment. And so I put it on the main top page. I'll let you know kind of what the feedback I get is. But if you want to look at it, you can go to centralmasspodiatry.com. Go to up top. It says the plantar fasciitis course. It's basically divided into 2 weeks of content that gives patient information about plantar fasciitis, kind of starting simply and with these short little videos. So that's something I'm kind of working on. I'm always trying something new. Larry Hupton as well, he did his own course. He's got a couple of courses. One was on skiing orthotics. I think he has one on hallux limitus as well, so he has one on his website. If you want to look at a really good website and join his list, it's called footandankle.com. It's his website, and he's got a great email list. I always think it's good to join other people's email list to see what they're doing. The other thing I'm trying to figure out, and I'd like to get feedback if you have any good ideas for me, you can email me, don@podiatrypracticemastery.com, or text me if you have my cell phone. But I sometime in the past, I did something called the Podiatry Management Minute. And so from that kind of spun off this $1 Million Minute thing. But I was doing it along with Barry Block and something for the PM News. And I wanted to do something. I'm struggling a little bit about the consistency and format of doing it, what I'm going to call it. He wants something that's 2 to 3 minutes. And then it gets a little more complex. He'd like it so it could be with captions in it. And I don't want something that's video. I just, unless I want to show something, I think it's good if I show a picture or I want to explain something. But I think for the most part, just an audio would be a lot easier. So I'm trying to figure out something that's not going to stress me out to do. So if you guys have any good ideas of how to repurpose some of this stuff, or kind of an easy way of doing that, I'd love to know. I'm struggling because I don't want to have another commitment. I would love to have an automated process. Let's say I did a 3 minute, 2 to 3 minute video, or audio, and then it could automatically make a little. I was trying to figure out how to do it with ChatGPT, basically taking the transcription from YouTube and then making a little write up on it, and then giving it to Barry kind of automatically. That's what I'm kind of looking to do. I haven't quite figured it out. Okay. Let's go into the day. This was a recording on a Tuesday, and there were 22 patients. There were 0 openings. Once again, this is my more established practice in Worcester. Okay, first patient was a follow-up. She's a follow-up for ingrown toenails. So for her, I did a nail avulsion 3 months ago on both of her big toenails. She had previously been on terbinafine. She had been on itraconazole, and that still didn't work. So now I'm going to put her, she was on terbinafine, then she was on diflucan, and now I'm putting her on itraconazole or Sporanox. So this is the third one, and once really there's 3 and they don't work, then there's no other options for me. If you have other options that you do for patients, I'd love to hear about those. So I put her on that, and I'm going to see her back in another 3 months. Next, so I do the pulse dosing. I do 2 pills once a day for 1 week and then 3 weeks off. Next patient was a 52-year-old that had insertional peroneal pain. So this is number 3 of 3. I'm going to see this patient back in 6 weeks. So I did an office visit from the last one. I'm tending to do more 6 treatments now, but this patient wanted to make sure they were getting better after 3, or the 6-week follow-up before we did any more. Next patient was a 62-year-old female that I did a bunionectomy, and I noted that the screw was a little bit into the first MPJ, and it's causing her a little bit of pain. So I am going to be scheduling her for screw removal. She's I think she's 4 months post-op from that. So we're going to schedule that. I opted not to do that in the office just because I think it buried a little bit, and That's something that can sometimes be hard to get out. So I'm going to do that in the OR. I've only done one of those screw removals in the office. It was kind of a bigger screw, and it was almost like poking out, but still it caused me to sweat a little bit in the office. Next patient was a 63-year-old. This was a patient that did shockwave number 2 of 6 for the heel. I did also scan this patient for orthotics, so that would probably be my most valuable patient of the day. Next patient was a 65-year-old patient. This is a new patient, came in, got x-rays, had foot pain in the heel, so an office visit. He had calluses on the heels with fissures, so we got my fissure protocol, which is carry 42 in the morning with some heel cups, 2 heel cups to prevent friction, and then the sleep and heel socks at nighttime, and he's going to come back as needed. Next was a 42-year-old for Swift number 3 of 4. I see them kind of getting smaller, but they have one more left. Usually for Swift, I'm trying to do it at about a power of 8, 7 to 8, and I do 6 zaps for 2 seconds each. Next patient was a follow-up from Charcot. So this patient had Charcot. I sent them for a crow boot. They got the crow boot. I'm going to see them back in 3 months for another X-ray. I got some new X-rays today. There was like the cystic formation, and kind of look like it was actually getting worse from the initial one, but it has to kind of break down before it rebuilds. I also referred her over to a podorthist because she's going to need to be fit for custom shoes afterwards, or at least a custom diabetic shoe that's a little bit deeper. Next patient was a 64-year-old patient. This is a patient that got x-rays, got an ultrasound, and this patient, when I did the ultrasound, I didn't see that it was a lot thicker on the right side than the left side. And so for these are the ones I feel like he would do okay with an orthotic and not doing shockwave. His pain wasn't all that bad. And so for this patient specifically, that's why I didn't do the shockwave for him. Was not that thick based on the ultrasound, but we did the x-ray ultrasound office visit. I did Celebrex for him so I could bump up the office visit, and then did the orthotic. Next patient was a number 2 of 6 for plantar fasciitis of shockwave. Next patient was a 59-year-old that had cyst recurrence. So I've aspirated, I think this is the 3rd time, at the DIPJ of a second toe. There's a cyst that keeps coming back. I did talk to him about doing surgery. In that case, it would be the cyst removal with the fusion of the DIPJ, so it doesn't come back. I did say you could do a simpler one, but there's a kind of a high chance of recurrence. So he's going to think about that. It's not all that ugly, so I aspirated it today and had him put 1-inch Coban around it. Next patient had a fissure as well. I think it's wintertime, so more fissures, 60-year-old fissures. I did the fissure kit as well, which I said before, which was the 40% urea, the heel cups, those plastic heel cups, and the socks with the gel stuff in them. Also, he had a nail sample, so I did a nail sample, and I'm going to see him back in 3 weeks to go over the nail sample, also because I want to see how his fissures are doing. And he had some issues with neuropathy as well, but I think the neuropathy was due to his back. He had a nerve ablation, and he had some back work as well done in the past. I recommended some topical things for his back, but it's hard. Those back patients with like the tingling due to neuropathy or nerve pain could be a challenge. Next patient was a 72-year-old. She had number 1 of 6 for shockwave for her plantar fasciitis. So today was the day at this office. I have the radial shockwave, which is Curomedics, and I have the softwave. So I'm liking the softwave a little bit better because I think it has a bigger surface area. I don't know how the final results are going to look. The unfocused, which is the softwave, versus the focused, what we have at the other office. So that was the morning. Afternoon, there was a patient that came in, status post physical therapy for the foot pain. They're doing much better, so no need for a follow-up. Another patient was Swift number 1. This is a 36-year-old female. And she's had warts, I think, for like 3 or 4 years. She had seen a dermatologist for a long time, and they were just using salicylic acid. So she did Swift number 1 of 4. So she set up the other 3 as well. Next patient was a 45-year-old that got shockwave. This is shockwave number 2 of 6 for his plantar fascia. Next patient was another shockwave number 3 of 6 for Achilles insertional tendinitis. Next patient was a 71-year-old patient with got an X-ray, had right fourth met head callus. That was quite painful for the patient. So I trimmed down this callus. It was kind of like a porokeratoma. So I put in possible wart, possible callus, and I did the lesion destruction for that. Next patient was a 66-year-old. This is a patient that would come in for an annual visit. She had previously been made a really kind of supported orthotic high medial lateral flange DPL cup for her posterior tibial tendon dysfunction. She's been doing much better with this, along with her good supportive shoes. Next patient was a 71-year-old female. Got an X-ray. She had arthritis. So she had midfoot arthritis that was quite severe. And I did X-rays, kind of showed her the arthritis. She already has a nice high contouring orthotic. She's comfortable. She is not in a ton of pain. So I just kind of left it at that. I reviewed the X-rays with her, and since she already has an orthotic from us, I didn't recommend doing anything else for that. She had also some pain or some concerns of neuroma pain in the third inner space, and we talked about just doing a little bit wider of a shoe. She came in with like this Nike shoe, which is way too narrow, and so I just recommended doing kind of a wider shoe. Next patient was a 54-year-old. This is a patient that came back. She had a diabetic foot exam. She also had kind of concerns of a neuroma. I offered her a cortisone injection, but she was not interested in that. She really just was concerned about having her toenails removed. And so she was referred over from her diabetic doctor. The reason they recommended her is because she used to have a very thick toenail, and it actually got onycholytic, and it was detached at the base of the nail, and there was some space in there. Some sort of an injury happened, and so the new nail grew underneath it all the way to the tip, and so this tip was just attached, and it was quite painful for her. So basically only the distal 1/4 of the nail was attached and thick, and the new nail was growing underneath it. So I just removed that. Did not have to numb her up. And then I used a Dremel just to Dremel down a little bit. As you notice, you've probably never heard me talk about Dremeling. I do not Dremel. We don't Dremel in our office. The only ones I would Dremel for would be like if I'm doing a carry flex or an Onifix where I'm needing to prep the nail bed, or like in this case where it was this nail was really painful for her. Finally, last patient was a pre-op for a sesamoidectomy that I'm going to be doing soon in surgery, and I did some pre-op shockwave for this patient. So those were the patients for the day. Another thing that's going to be happening, I have one of my listeners here. I think he's going to kind of get into regenerative medicine, so he's going to be working with an anesthesiologist, and this doctor is going to come and visit me. I'll probably tell you about it probably next week, I think it is, to learn how to do diagnostic ultrasound, possibly to do these regenerative, probably PRP or something similar. So I'll tell you more when I learn about it. But once again, if anyone wants to come and visit, I'm always happy to have people come and visit. It always makes it more fun for making content. And once again, if you have any other ideas of how I can maybe produce short form, like 2 to 3 minute, punchy types of things that would help Barry Block and PM News, that would be helpful. Okay, thanks.